it is obvious that the most rapid one will be if we have all the things, including treatment of latent TB infection as part of the options. Otherwise, it is going to take a longer time if we just treat active TB, or if we do any other things like, mitigating risk factors and so on. It's quite obvious from the graph. What are the options available? You see, it's quite clear again that the current available tests, whatever we have, are really are not as good as we would desire them to be. And therefore, you see, there are certain recommendations which have emerged that we would treat even without testing. And one of that is the people who are living with HIV. I think that's been there for a very long time as a recommendation. And the second is that household contacts of index patients with tuberculosis. To start with, children 5 years and under are the preferred option, and then once we achieve this, the coming recommendations are that even all adults and adolescents and children above 5 years would also be given this intervention without testing. And then there is a group, you see, amongst the HIV negatives, wherein one would need to first perform a test to ensure that infection is there, and only then subsequently treat. And this, group is of that patients who are really on some sort of immunosuppressive treatment, or receiving dialysis, or preparing for organ transplant and so on, so that their immune status, whenever it's depressed, I think in case they are infected, they would need treatment. And in fact, in certain countries where low incidence of TB is concerned, this test and treat policy is considered even for, groups like congregate settings, prisoners, health workers, immigrants for countries with a high burden of TB. I mean, we have many situations here where, you see, when Indian go to, say, the US, and the tests are done and they are found to be positive, and then they are insisted that, well, now you must take the full treatment course for LTBI. So they are anxious, but then that is again a recommendation here that if one migrates from a high incidence country to a low incidence country and tests positive for infection, one would need treatment. At the present juncture, you see, systematic testing for a group of patients who are having diabetes is not yet recommended, or maybe excessive tobacco use or alcohol use. I mean, this is still not to be done on a systematic basis, but on individual basis one could take depending upon risk factors. And the cascade of care is, I think it's very simple. You identify the people at risk, then you evaluate them to rule out the active disease. This is very important. One has to rule out active disease, because otherwise you are giving subtherapeutic treatment for a person who maybe is actually suffering from the disease, and you are giving latent TB treatment. And once those who require to be tested for it, as I've already stated, you would do it in that situation, and then continue on with a particular regimen that you think, and monitor and ensure adherence. And finally, you see, report on this. The regimens here are, WHO guidelines 2018 stated that, the most strongest recommendation with high quality of evidence is for isoniazid monotherapy daily for 6 months. Now, this is for high TB incidence countries, and even for low TB incidence countries, this is the current preferred option with a very strong recommendation. Then there is another recommendation which is also very strong, but evidence is a bit low, and there rifampicin and isoniazid for 3 months, it could be offered as an alternative. And especially, children and adolescents less than 15 years with high TB incidence in the country. And this 3HP regimen, basically 12 doses rifampicin and isoniazid weekly for 3 months. This is at present a conditional recommendation, even though the quality of evidence is moderate, but still it continues to be a conditional recommendation. For low TB incidence countries, again the options are very clear that okay, some countries are adopting 9 months of isoniazid, some are adopting 3 months of rifampicin plus isoniazid, then isoniazid plus rifampicin, or rifampicin alone is also being offered as part of the treatment options. People living with HIV, there is always an issue that whether when to stop, and certain recommendations have emerged. It's again conditional that one could continue isoniazid alone for 36 months. This is some published data on this, that okay, if you do this particular intervention for people living with HIV, it reduces the risk of active TB. It's from the Cochrane Library. And this is again a recommendation that rifampicin and isoniazid, the 3HP, will give comparable benefits and in fact greater completion rates. 4 months of rifampicin or 9 months of isoniazid for latent TB. I mean, Dick Menzies did analysis, meta-analysis, and here again we had a higher rate of treatment completion and better safety. And then you see there is this newer thinking going on that we could shorten the treatment to even 1 month with a daily, isoniazid and rifampicin. And this is also proved to be non-inferior to the 9-month regimen. And of course, the treatment completion rates were highly significant.